We're not sure that they needed, we talked about apps, we're not sure they need an app, they just need help. But they've got to make the decision first. So that's the first thing, is that we started getting into the decision-making process of, yeah, obviously a bee sting as something hurts, right? So maybe I'm going to do something about it, but that's not necessarily evident in all health conditions. So there's an anxiety concern has to grow before they actually want to go and find either the app or help. And an app or a website is not necessarily always the best starting point. So it's sort of online, what can you do? And there was a debate around, that we always give fair balance, and also it's not individual, so it's general health information. And then we had a discussion about, are we pushing, are we giving people the choices as opposed to the information? So where can they get the guidance, diagnosis, or whatever it is they actually really need or want? And so that was quite an interesting debate. Recognition that all patients are individuals. So at this point, I had to put a beard on the second bloke, so he's different to the non-confident bloke because they're individuals. And this guy,
he's poor as well. So.
They've all played. They've got no money. And he's been diagnosed. So is he he's not looking for the same kind of information in a different state. There's still a sort of confidence element, a different set of choices. So we keep coming back to this idea of choices, and still using, we think, the same sort of search criteria. And then we kind of concluded by sort of, actually there's no real common understanding of diseases, and there's actually a lot of misunderstanding of diseases and myths. And that's, I suppose, I came back to, where do people go? And if you're not confident and you have a bee sting, then you might go to your grandmother, and your grandmother may tell you that if you wrap it up in brown paper, or run it under the tap, or whatever it is that, or put oil on it or something, whatever the what we would call in English the old wives' tale is around that health condition, you would trust, because you trust your grandmother or your mother or your father. It's not a sexist thing, honestly. And that's where we got to, I think. So I just did lots of drawing and did lots of interesting conversation, and I'm not sure we came out with any solutions. So, do I do?
Your trust filters the grandmother.
Well, that is, I think, the recognition that people's trust filters can be not necessarily health, or health specific. So it could be, for me, media. So TV show about health, we have them in the UK. People trust them, people watch them, and then hopefully they go and get health advice afterwards. But, likewise, people would trust their mother or trust their father, or because they would trust them in every other part of life. Mike, sorry.
I think for me the big one that came out of me is management of worry. What's my worry? And if you've got an expert that says don't worry, your algorithm of trust then for me goes, okay, I'm all right. I am still worrying, but he said it's going to be all right.
What if the expert says worry?
Well, I'm not sure if I don't know. I don't know if that shared decision making, whether that's a good one, whether to raise that fear and anxiety. Because I think I would say that humans are programmed to go on the other side, to actually say, don't worry, or don't worry, but you guys, you need to sort him out quickly. Come on, but don't tell him.
Right.
So so everything's for lessening fear and anxiety.
It makes us feel better if we're not putting someone out in it. It's for ourselves that we do that. It's not necessarily for the patient.
Right.
So but again, people are uncomfortable with anxiety.
But again, it depends on your type of condition. Some people, more information make them feel in control of their choices. Other people, more information just makes them overwhelmed and annoyed. So it's
but often you've got to pick: are you treating the physician, or are you treating the doctor? Treating the patient, or are you treating the physician? And so you have to keep that.
With the information that you put out.
Yeah.
Yeah.
Makes you say,
Andy, thank you very much. Top job.
You want this?
Yeah, hang on to them. Just
I'm going to start a collection.
We'll make a start. Winter's coming up and Finland's and ships. So, if I may, they're already on the feet. Look at that. And I've got to scan that QR code.
I did, and I tweeted the picture of what came out. Could you come help us?
I've just realised I missed that India. It's supposed to be in there.
It's okay. Yeah, we're sending out big welcomes to the newest member of the healthcare social media community, Hicks in India. Hi guys. Oh, I've got a whole.
Thank you.
What's wrong
Back
with
up.
the board?
A little higher. A little higher.
How about here?
Perfect.
That's your best, right?
Audits contributions from the back.
Still,
I've got headphones, but it's difficult to move it anyway.
Nice chat.
Now you look like me.
All in on the review, right? Well, knock us out, guys.
Right, you're on. I can't do anything in 10 minutes. It's terrible. We had a very interesting discussion because for the first 40 or 45 minutes, we tried to decide what a filter was. Right? Did you guys have that in your groups as well, or did you just agree that there were filters?
We were very comfortable with filters.
We threw it out there, but we decided that we'd just waste too much time if we discussed that.
I think we found that people once they got a filter, the idea of a filter in their head, we agreed pretty quickly what it could be, but then we didn't agree that that was the best word to use.
Right, so I think we thought more about guidance than filter, okay? You know, it's interesting, Celia, that you said that Google is the best filter. We talked about that, and I think we didn't agree.
No, I don't think it's the best filter, but I say it's the one it's the default one that seems to do its job.
Right, but that becomes an aggregation issue rather than a publishing issue. So is it where you should go? And I also thought, and this is going to deviate for 1 second, you know, that bee sting issue was an interesting point, because if you go to Google after you get a bee sting and you're anaphylactic, by the time you get the answer, you're dead.
Google are working on it though.
Right, it's the EpiPen by Google.
Carried by every bee.
So when
Right.
the keyword search was only the word bee, because they haven't had time to write sting.
And it brings new meaning to the escape key, right?
Bees are now no longer going to be black and red. They're going to have the logos stamped on
So
them.
only when Google personalises the experience down to the level of knowing the patient's healthcare, and obviously their vault has been switched off now.
Tried that.
Yeah. Okay.
Anyway.
Cool.
Well, you took the notes. You have words up here we didn't even say.
It would be my doppelganger then. Okay. You made notes, and I can't even see them. We decided here that within the patient there was a very important element, which was the carer as well. Not all conditions are going to involve just the patient, and there's a great deal of information that could be had there. And they also search for things as well.
Yeah, and I think one of the things that we touched upon, and one of the most important points, was findable doesn't mean credible. So that's where that definition of a filter was really important. And you know, Rob led us through the session really well. And you know, we were talking about maybe those filters wind up being traps. You wind up thinking that you're finding the right information because you trust what you find and you find the wrong thing. We talked about the vaccine example. If you look for vaccine information on the internet, you will find the wrong information before you'll find the right information. You'll find a paper that was retracted very quickly, still being cited in 2011 when it was published in, anybody know? 1994. Right? Wakefield. 1994. There are probably people in this room who weren't born in 1994. Everybody in this room has been vaccinated since 1994. Right? But there's a point that, you know, that information is findable, but it's not credible. And by the way, John, and everybody jump in if you think there's other stuff. You know, then we thought about, you know, maybe we don't need one filter, we need many filters because there's so many audiences. We talked about the healthcare professional audience, the caregiver audience, you know, the family members. We talked about the patients. We talked about the information that's being looked for by each of these audiences. We also talked about the overlap. So the physician as consumer versus the patient who looks only on the healthcare professional sites. How do we make sure that the information that's being found is the right information? And then we had the benefit of talking with a practicing physician who talked about how is this done now in clinical practice? How do we send the patients to the right places? And something the last group, Dowage, mentioned, right? Andy, you talked about that time points. That's critical because somebody's looking for different information at the point of diagnosis than they are 2 years later, 5 years later in a chronic disease or at that point of B-state. So all of this stuff is important. We always think of that snapshot, that one moment in time. And the reality is we have to think about the breadth of information. And then I think maybe the...
Yeah, so it's what we did. We took this idea of the filters coming out from the healthcare professionals, talking to patients and them offering selected sources of information. That doesn't have to be just on the web, that can be the phone, it could be a hard copy, things they're giving out. But what we then decided for the active patients, and remember, not all patients are the same by any means. Some patients do not want to become active. They want the doctor to tell them. They like the patrician kind of approach, and they're not going to engage with this model that we're discussing here. But what they want is to kind of have an element of trust that's brought in to know that these sources of information are well regarded. And then what they want to do is to choose their own filters, if that's still what you want to call them. But you're going to have to segment those down. It's no point saying we have a kite-marked set of information here. It's not going to be relevant to everybody. They're not going to believe everything that they read, even if it is creditable, because they have their own ethos around the conditions that they've got. And then we spoke a little bit about how medical training kicks in on this as well, and how you can actually engage with the patient at his personal point.
Yeah, we talked about knowing your audience, right? We talked about knowing your healthcare professional audience, knowing your patient audience, and no audience is homogeneous. You can't just say, here's the piece of information that every physician needs. Here's the piece of information that every patient needs, because every audience is heterogeneous. So we talked about, we got a little geekishly scientific. That was the word.
You were allowed to use it.
Thank you. Well, because I said geekily.
I know the discussion behind that.
Well, he said I spoke American, and I said I spoke English. But we talked about sort of that bell-shaped curve, and we all fall into that bell-shaped curve, right? Some people are to the left of the midline, some people are to the right of the midline, and we have to make sure that information fits there. And we talked a little bit scientifically about the trans-theoretical model of Prochaska, of how people, some are looking for data, some are looking for just tell me what to do, some are looking for something that everybody else is doing. And then we talked about, and Messina brought this up, the ICE model of training. And we went and we found the McWhinney 1984 reference of the disease illness model, and Messina's tweeted that, so if you want to look at that and read this wonderful 867-page paper, we can summarize it later. But basically, it's how physicians in some medical schools, including Imperial College, are being taught how to have that patient-physician interaction, right? The consultation. ICE. It's ideas, concerns, and expectations. What ideas do the patients come in with? What are their concerns, and what are their expectations? And how in those 10 minutes can you examine and then set those expectations that's right? And then we talked about those expectations may change over time so that the information that eventually gets filtered and looked for by the healthcare professionals and the patients is findable, credible, and right.
And that was the kind of algorithm that we can bring through from the second group that presented. There was an engineer, the application engineer in the room, and saying if you get patients to self-select these things, then they can come out with their own set of tools even that they can then use. They've selected their own way of getting to the information that they want to see.
Yeah, because no matter